Thank you very much for inviting me. It's a pleasure to be here. And I'll be giving just a few little anecdotes that hopefully will relate either directly to the precision medicine or maybe in parallel to precision medicine. And I'm going to start with my perspective because people always find this interesting. So this is the world with New Zealand at the centre. And you see, we're a long way from anywhere. So I studied engineering. And while I was doing engineering, I was speaking with someone looking at babies. And I spent half my time in the engineering school and the other half of the time sitting in this is the pediatric outpatient ward unit in America in the Christchurch Hospital. And some of the time in the nurses, this is the old nurses' hostel. And there are two kind of formative anecdotes I want to talk about here. My colleague, I was looking at breathing from babies. My colleague Craig Tufnell, and good friend, who would sit beside me, was looking at temperature, and he turned a baby into a model, 3 compartments. So there's head, trunk, and blood. And he wanted to just model what happens with a baby's temperature during sleep. And on the left, we have what happens in a real baby. You see temperature drops, and we have oscillations. And this is what his model showed, which was kind of similar. So in other words, turning a baby into 3 boxes, we can actually replicate some of what we see in a real baby. Now, at the same time, in the room next door to me, I was sitting with these community pediatric nurses, or community nurses. There's not quite an equivalent in the States, but these will go out and they were doing a study on helping pregnant mothers reduce smoking. They would go sit in with these mothers-to-be and just work with them individually and find their goals and just help them cut down their smoking. So these two experiences have, on reflection, helped inform my outlook. So I came to the States to look at obstructive sleep apnea. And this was in adults, although I've done several other studies in children. And so I'll be looking at obstructive sleep apnea from now on in the talk. And obstructive sleep apnea, its proximal cause is essentially that you have this upper airway muscle, and for some reason it loses tone. So when people go to breathe in, the airway muscle gets sucked against the back of the throat, and it causes a blockage. So that is obstructive sleep apnea. And there's a few symptoms that are classically associated with this. So snoring, especially gasping or choking. Snoring has been a classical symptom along with daytime sleepiness. Also, in terms of what's considered a normal symptom, fatigue, and this is more along the moving into a sense of like depressive symptoms, morning headache, and these latter two are more common in women with sleep apnea. Why do we care? Well, one reason is we have an increased risk for all-cause mortality. So this is a study out of Australia. And again, I'm from New Zealand. So this is a 6-fold risk of mortality over a 14-year period in people diagnosed. So these are people who are actually presumably treated. And probably what's going on is that the stress of the sleep apnea is leading to other difficulties. And so if we look at what are the actual problems, well, we have many comorbidities, physical and psychological, beyond just the sleepiness. And our treatment of choice, CPAP, doesn't really resolve these comorbidities. It can help. Furthermore, the first thing someone will say to you if they're diagnosed with sleep apnea is, well, I don't want to use CPAP. Who wants to wear a mask for the rest of their lives while they sleep? And so there's low compliance and it's disliked. And even people who want to use it still struggle with it sometimes. A lot of people we see, this is probably biased because of the people who come to our study, but I feel like I should start dancing. is that they're frustrated that they're using CPAP, but it's not, they still have trouble thinking, they still have trouble with depression, they still have trouble not feeling well, and this turns out it's more common in females with sleep apnea than males. Females are also less likely to be diagnosed. This is changing somewhat, but it has traditionally been seen as a male disease. And I love there's this, from the 90s, there's this one paper talked about females having abnormal symptoms, as if the correct symptoms to have were male symptoms, and the females were causing an inconvenience by having abnormal symptoms. So, and while it is less common in females, it does seem that for the same level of disease, women are more affected by sleep apnea. So let's look at what we know. Research, this is just a fun way of looking at the amount of research articles per month in PubMed. So you can see it's up to 200-300 a month at the moment. So thank you, NIH. And a fun way of looking at what are people researching. So let's do this with a word cloud. So we take all of those publications that have an abstract. Let's look at what words are in there. So these are the most frequent words in those abstracts, which will give us a sense of what's been studied. So we see treatment, CPAP, years, disease, breathing, surgery, used to be very common, treatment, pressure, respiratory. What I don't see in here is what I hear people complain to me about. People who are struggling in their job, they have a professional job, they can't think, they can't remember, they're feeling not just sleepy, but just not able to carry on. So it's more in the realm of something we would call stress. If we measure anxiety symptoms or depressive symptoms, anxiety symptoms come out highest, but I'm not sure that you would say it's an anxiety disorder per se. So a lot of the research then is not getting at what people complain about. And so then we go, well, where are our knowledge gaps? Well, I would say, what is the source? What's going on? Why do we have so many symptoms beyond just the sleepiness? Are there alternatives to CPAP? Are there effective alternatives to CPAP? This word effective is interesting. We'll get back to that. And why do symptoms remain with CPAP? So, in this study, although the title was very absolute, no cardiovascular benefits for CPAP and OSA, it's probably an unfair title actually based on the study, but this is what the point is, that even if CPAP does help, it doesn't fix, it doesn't resolve. So I've been looking at what the brain might have to do with all of this, and so we can come up again, engineer, let's have a simple model. Sleep apnea, brain injury, brain doesn't work so well or is altered, and then we have some symptoms. Simplistically speaking, this is consistent with what we might see. Remember we said this treatment, the CPAP, doesn't seem to fix everything. So, okay, how does that fit here? Well, presumably CPAP it effectively stops sleep apnea. It's basically what it does, is it stops the blockages in airway and air keeps flowing. It's like a reverse vacuum cleaner if you're not familiar with it. And so this would stop further injury, but if there's existing injury, it wouldn't treat it. So perhaps what's going on is even though you stop more damage, the existing damage remains. That's possible. This was sort of supported by animal models from almost 20 years ago that showed that with 2 days of intermittent hypoxia, which is one of the characteristics of sleep apnea, you get cell death, which is represented in this slide. And so the first study I did, which is actually still my most cited study, was looking at a patient, a small group of people with sleep apnea, used MRI scans, and using the traditional way of presenting changes that we have in neuroimaging, we have a background, in this case a sort of grey image. It's fuzzy because it's an average of 40 images. That represents areas, and then in these coloured blobs, we actually call them blobs, that represents statistically meaningful differences. And in this case, where there was a smaller hippocampi, and or smaller grey matter, and then we've got the hippocampus as one area that keeps coming up. So And more recently, we can zoom in, we have much higher quality images. So this is the hippocampus in yellow. And we have this image here, which is looking just at the hippocampus. And so this gray shape that's there, and we often rotate because it's easier to see a 3D shape with rotation. So that represents an average hippocampus. We each have these, one on each side. And the colors represent areas where there's a change in the volume. So the red orange is actually a swelling in this case, maybe some inflammation. And the blue is sort of a shrinkage, perhaps reflective of damage. And it was interesting, we were talking about this precision medicine initiative to get those sensitive measures of change. You actually see we had 66 sleep apnea subjects, which is fairly typical for a neuroimaging study, but close to 1,000 controls. And this is where we used a large population study of MRI scans, and then we could take our 66 subjects and compare it with those. And we had some of our own controls as well. But I think this is a small precision or low precision, but we didn't have 1 million, but having many, many measures that we can then bring in with our study does two things. It makes our study more sensitive, and it means that another group can take those same measures and compare their patients against them. So I think this is just a little aside to a sort of a shout out for, I think, that all of us is, if it's done right, has got value. Now, just to complete the loop, recently I wrote an editorial, so this is my 2 cents worth, and it's called Damage to the Hippocampus and Obstructive Sleep Apnea, a Link No Longer Missing. So there was a group in Scandinavia, and I worked with an Australian team to look at post-mortem slides of people who are known to have sleep apnea, and they found that indeed in the hippocampus there was damage. So this is a region in the non-sleep apnea post-mortem slide showing that when it's a thicker CA1 area compared to the sleep apnea, and this was looked at a population level. So we went from animal to human imaging to precisely looking at the hippocampus to seeing that, yes, in post-mortem studies there really is a difference as well. And I'm just going to briefly touch on, well, how does this relate to symptoms? And so one symptom, this first one I really was interested in was depressive symptoms, and roughly half of the people with sleep apnea in studies report having high levels of depressive symptoms. Again, this is not necessarily a depressive disorder. I actually think this is an underestimate compared to actual clinical populations. When we try and study people and we try and exclude people on antidepressants, that cuts out about half of the people. I would say it's probably closer to 2/3. And why do we care? Again, when you add depression to sleep apnea, things get worse. So commercial drivers are at high risk of accidents if they have OSA. So there's a threefold risk just from having OSA. But if you have that with depression, you can go to over 6-fold risk of crash. And so this is a study we did several years ago that looked at, well, okay, so we have high levels of depressive symptoms in some people with sleep apnea, but not others. So let's see if there's anything in the brain that also changes with that. And this slide is from a paper that showed that the people with more depressive symptoms did indeed have markers of, in this case, damage compared to people with sleep apnea with lower levels of depressive symptoms. So in other words, those with symptoms also had markers of some kind of change in the brain. And we've looked at anxiety as well, and also some physical symptoms, so diabetes and hypertension, which I won't show the results, but we have those findings as well. So then what about sex differences? And we have sex differences in symptoms and presentation. So at first we weren't focused on this, but several years ago I was walking past the poster at a neuroscience conference that showed an animal in vitro study, and this is the paper that came out. It's called Sex Differences and Susceptibility to Oxidative Injury from Intermittent Hypoxia. So, in other words, they took slices, brain slices, I'm not sure if it was a mouse or a rat, and they exposed those slices to intermittent hypoxia. Those from the male brain showed more damage than those from the female brains. So I thought, well, that's interesting. And we did the same study using imaging in humans. And we found that indeed there were differences. And this is an area that the NACNR has supported me for several years now, is to really look at what we see in the brain separately in males and females. And kind of a nice piece along this, I'm going to go back to, this is our hippocampus. This is essentially the same representation as that big hippocampus. It's got a slightly more stringent statistical threshold. So again, we're looking at roughly 1,000 people versus 66 people with sleep apnea. We see a few areas, again, they're smaller because of a higher statistical threshold. And we included sex as a covariate because we knew it was important, and that's what we saw. But what happens if we look at men and women separately? So rather than having one big model, we put everyone together, and we have a statistical control for sex. Why don't we look at males and females separately? So we did, and we get something quite different. So if we look at males separately, using the same population, the same statistical threshold, so again, we've got roughly half the number of people here compared to there. So if anything, it should be less sensitive. We get this, and I'll explain this in a moment. If we look at females, we get this one on the right. So the first thing that should be obvious is that there are a lot more colored areas here and here than on the left. So if we had stopped at this finding, we would have said this is the effect of sleep apnea on the brain. But when we take it one step further and just go, well, no, I don't want to combine, I want to look separately. So roughly the group of 500 males, roughly the group of 500 females, and we go, what's the effect of sleep apnea? This is what we get. And so we see both, there's a whole lot more that shows up, and also we see differences, and I've highlighted one here with the star. So this is the tail or the posterior hippocampus, and this is an area that's tied in with depression. Females with sleep apnea tend to report higher levels of depressive symptoms, so there's some association here. So obviously there's the immediate finding, maybe there's some biological underpinning of the differences in symptoms, but also it has a message that combining male and female, and perhaps other combinations, can hide what's actually going on. So let's look at possible mechanisms. I'm going to focus on one that's kind of recent. Working with a group of people at UCLA, my colleagues, collaborators for many years, we have techniques where we can look at levels of chemicals in the brain, so NAA, which is related to neuronal function, glutamate, and we can get these maps across all different areas. And so a preliminary study we did was to look at GABA and glutamate. So these are the most common neurotransmitters in the brain. And we'll start on the left in the GABA. So what we have here, we've got a structure called the insula, which is key to many of the symptoms. And we've got the left side and the right side. And in the grey bars are the sleep apnea, and the white bars are the healthy controls. And what we see is the grey is lower than the white, the grey is lower than the white. If we go to glutamate, the most common neurotransmitter in the brain, we see the grey is higher than the white, grey is higher than the white. Now, how do we interpret this? Well, since GABA is considered inhibitory, we could think of it as like the braking, slowing chemical. Since glutamate is considered excitatory, we could think of it as the kind of accelerating chemical. And then using the simplistic metaphor, then we would say the sleep apnea patients have less brake and more accelerator. Is this related to the very high sympathetic tone, high levels of anxiety, or any other measures of stress? My students just finished last week presented a study looking at perceived stress in people with sleep apnea. That's also high. And also we know that high levels of glutamate can lead to excitotoxicity. Now, of course, I want to know, is this different in men and women? And that's what the NHLBI has just funded me to look at. So I'm at the beginning of an R01 for that project. I wish I knew the answers now. So this is the pilot data for that grant. I'm going to touch on a couple of interventions. First is CPAP. So this is another 2 cents that I had. And there's a couple of groups, one in Australia and one in Italy, that have published studies showing that if you treat people with sleep apnea, it does seem to reverse some of the changes in the brain. So this is promising. There are some caveats to that. We have some preliminary data that suggests that as well. And going to symptoms, and this is, again, pilot data for another grant that we're trying to get funded. We have the cross-sectional study of looking at cognitive performance using a very simple 10-minute test. And we have the healthy, untreated sleep apnea on CPAP. With this measure, with this group of people, we found that the treated sleep apnea and healthy were similar levels. The untreated were lower. This is consistent with what people report as they have trouble thinking, trouble making decisions, especially if they're in a profession that requires a lot of intellectual power. I've got the males and females separated out there. Then we look at depressive symptoms in the same group. We see it's low in the healthy group, and it's high in the untreated group. And then we see this difference between the men and the women in the treated group, where we have even higher in the females, high levels of depressive symptoms compared to the males. So again, does this hold? We don't know. So the Office for Research on Women's Health, along with NACNR, have supported a kind of R56 to sort of start looking at this and link it to what's going on in the brain. So the final piece, which is looking at another intervention, this is inspiratory muscle training. So if you remember, people don't like CPAP and it doesn't always work. And if we go back to just looking at things very simply, like I said, if we take the turn the baby into a box approach, what's happening with sleep apnea is this tongue muscle, if you like, is losing tone. So what if we just tone that up? How do we tone up muscles? We go to the gym, we do weights. So how do we do this with this muscle? It's not easy to do. The first study related to this was looking at playing a didgeridoo. So what happens is people Google, they find they have sleep apnea or they worry they have it. So before they even go in for a sleep study, they go, what could the treatment be? They Google treatment, they see CPAP, they go, I don't want that. What else is there? So they'll say the didgeridoo. So when we see people, they go, what about the didgeridoo? And there was a very small study that showed that, indeed, playing the didgeridoo seemed to help. And maybe this is training those upper airway muscles. I think the original, I have a couple of didgeridoos in my office and they look way more cool like this. And it's tricky to play. This is the one they use for the study, which is much more boring. And so I had that in background. Then I saw a group in Tucson did this pilot study where they did something called inspiratory muscle training. And they found it modulated blood pressure and plasma catecholamines. And because I've been more focused on cardiovascular than respiratory, I immediately thought, hang on, you're doing a respiratory training, but you're getting a change in blood pressure and plasma catecholamines. Like, what's going on? So I immediately rushed out, bought one of the devices. We spoke with the PI about how they did their study. And so inspiratory muscle training, this is one way of doing it, and it's traditionally been used as in the exercise world. It comes like exercise training, performance, and so if you Google it, you get people who look like this, who are very cool, and don't look like someone with sleep apnea. And we started with the protocol that they use, and we ended up adapting a lot based on talking with the patients. But in essence, it's like a set of 30 reps if you've been to the gym, except it's breathing. So you breathe in hard 30 times, and then that's it. That's it for the day. And the typical studies have been 6 weeks. We did 6 weeks, and then we found we needed to extend it based on kind of talking with the people who are doing it. So this is another preliminary one where we're really trying to get more. And so this, we did sleep studies before and after. It's hard to say if there's any change. A lot of these people started with only mild sleep apnea. We measured blood pressure using these home devices, so we had a lot of measures. So we had dozens of measures. Maybe systolic went down. When we look over a longer period of time, it seemed to go down, but maybe it didn't. Sleepiness started very low, so it went down, but what does that mean? Here's what's interesting. People loved it. People really clicked with this. Now, again, they're in a study, so who's to say that it's not that they loved being with us in the study? But people reported feeling better. Like there's this, and they talked about their breathing feeling better. And this gets back to the very last question you had, I think, is that, well, let's say we find these measures and we find that, you fit in this profile, then where does what you want come in as a patient? And these people, in fact, there was so much positiveness that we didn't capture. We did a sort of mini qualitative study with some of our colleagues, but there's something going on where people were more than happy to use it, and they just felt good. There's something about their breathing felt good. Was it the actual muscle training? I don't know. I also do a little bit of mindfulness work. In fact, one of the training grants was for my student who did mindfulness and hypertension. How much is actually, perhaps through training their breathing, they're getting the experience of mindfulness, since a lot of mindfulness or meditation is based on breathing awareness. I don't know, but I thought it was very intriguing. And so so I think this idea of balancing, like looking at what do we choose, we have an All of Us initiative, like what do we measure? Let's think about the models. The models at least give us some way of narrowing down what's important.
Dr. Macey, you have about 2 more minutes.
Great, then I'll finish up. So
Maybe 90 seconds.
Very good, and I know you said that people should finish on time. So, and then this idea of like personalizing interventions based on what people want. So this is the people to thank. I think the slides will be available, so there are many. And here we go.
That was just such a fascinating talk. I'm afraid we're probably going to have a lot of questions. So I would like to give time for just 1 or 2 if there are some, if there is something. Shirley, did you?
So I'm one of the people who got one of the supplement grants on looking at Alzheimer's disease and related things, and we're using imaging, brain imaging, and as well as blood markers to look at. And I had never thought to ask if they had sleep apnea as one of my other indices that I do, because as I look at your thing, are the brain changes due to the sleep apnea, or are they other induced that were creating Alzheimer's, like, dementia? But it seems that when we do these studies now, we might want to add that question to more of our studies, because it looks like it could be, as we ask other possible confounding variables.
It was first in 2017 I started hearing one, then several talks about sleep apnea as a precursor to MCI and Alzheimer's. So I think this is a great example where just by adding that one question, it can open the door to looking at that question, to looking at that.